My name is Rachel Grob, Rachel Grob, and I am an associate clinical professor and director of national initiatives, as well as senior scientist at the University of Wisconsin-Madison in the Center for Patient Partnerships, and also at the Department of Family Health and Community, Department of Family Medicine and Community Health. Sorry about that, we just changed our name. So I have a complicated variety of roles, but I spend a lot of time educating future health professionals and even more time listening for patients' voices and engaging in a process of discerning what they have to say and then sort of synthesizing and amplifying what they have to say in an effort to make healthcare take them into account much more seriously than it does in the United States at least, and also to attune policymakers much more closely to what it's like for patients both to be sick and for community members to be working to stay healthy, and also what happens when they interact with the healthcare system.
Okay, so in terms of the patient partnerships and the education component, how do you bring what you do sort of into the realm of this conference? So how do you facilitate patients' voices? What are some of your priorities and your interests in doing that?
At the Center for Patient Partnerships, we have a blended learning curriculum. We teach in an interprofessional domain where we have students who are en route to becoming physicians, as well as nurses, pharmacists, lawyers, social workers, public health practitioners, psychologists, industrial engineers. So we have a wonderful, vibrant, interprofessional classroom that's both occurring online and face-to-face because we have a blended learning curriculum. We have patients really at the center of our curriculum in lots of ways. One way is that we have a clinical course where our students are matched with clients who have a serious illness and are having trouble making their way through the healthcare system or need an advocate for a variety of reasons. They have unanswered questions, they need help figuring out how to manage their employment while they're sick, or how to talk to their families, or how to get resources they need, how to find a clinical trial, how to get a second opinion, how to understand what's happening to them in the healthcare system, how to get insurance coverage for something that's being denied, those kinds of things. So our education pairs students with clients who are their teachers because the students are becoming advocates and learning how to do that advocacy work, and the clients are getting help from somebody who has a fair amount of knowledge and an intense passion to be part of that advocacy process, and are generously teaching these students what it means to be an advocate in many domains, but most particularly perhaps with respect to deep listening, to an empathic sort of slowing down so that you can settle into the rhythm and cadence and priorities of the person for whom you're going to advocate. And so it's a wonderful mutual relationship at the center of our curriculum. We also bring patient voices into our curriculum by having panels of patients come and speak about their experiences, either with being clients at our center or with other aspects of healthcare. And in the online environment, we take advantage of a wonderful database of patient experience that's been generated out of Oxford University in the UK, and now there are 11 other countries doing that. We are part of building that database, and it's a video archive that takes rigorous qualitative research studies about patients' experiences with a variety of things. Right now I'm doing one about young adults' experiences with depression in the United States, and we do in-depth, intensive interviewing on video, just like this is on video. We go to people's homes, we look for the most diverse set of experiences we can possibly get. So instead of looking to hear the same thing over and over, we look for what we haven't heard yet or what we heard an intimation of, and then we try to find people who might embody that aspect or element of experience. So there's great diversity in terms of socio-demographics, also in terms of severity of illness, how old you were when it happened, how it meshes with other aspects of your life, whether you take medication or not, how you interact with the healthcare system, what kind of community you live in. Are you more isolated? Are you more urban? Are you from an immigrant community where there are certain kinds of practices that would mediate your experience with depression, just for example. So it's a wonderful way to move from patient voice in the singular to patients' voices in the plural, which we feel at our center is a critical evolution in our ideas, our movement away from a more tokenistic and less developed approach where you say, oh, well, any patient will do. I'll just, as long as I have a patient, I'm good. I can check that box off. My students have been exposed to a patient. Well, each patient has a very particular and very sacred set of experiences, but to educate health professionals to work with a wide and diverse population, as in the United States is true for all of our health professionals, they really need that plurality of voices to understand what the constants are, to the extent that there are some constants, and there are some, but more importantly, what the differences are and what the diversity is. And so this video archive is a wonderful tool, and it can be integrated into both face-to-face classroom kinds of settings and into online or blended learning. So we're really excited about that.
That's amazing to do all of that and then do it in an online context. That's very exciting. I want to ask you a bit about what brought you as a health professional or health professional educator, what brought you to focus on the patient? Because strangely, it's not that typical.
Yeah. For me, it's been at the center of my passion to be involved in healthcare from the very beginning. Like many people, I got interested in healthcare because of an experience I had as a very young person with an illness problem with my knee and a recommendation for surgery. And so I've always been interested in healthcare from the perspective of the people for whom it matters the most, and who I think really kind of own it, and that is anybody who's receiving health services, and even beyond that, people who are endeavoring to remain healthy in their home and community environments. So I think my own trajectory was more, how did I become interested in being an educator? Because I've always been interested in the lived experience, the life world, the details, the stories, the narratives of people who, in a world that's not necessarily nurturing their health, are engaging in their own journey to maintain health, to build health, to recover health, to understand what it means to be ill, and to incorporate that. And I think that it's endlessly fascinating and endlessly important, because we're here to kind of express who we are, and illness can be part of that, illness experiences, but most of all, we want to have a society that makes it possible for people to find what they have to give and give it. That seems really at the center of things to me.
So, how do you think healthcare can continue to improve based on some of your experiences here today at this conference? Do you have any thoughts about that or insights about how the patient's voice or patients' voices or service users' voices can be diversified and brought into a central place in the discussion of health?
Yeah, it's a good question. I think, first of all, this conference is important and appealing because starting at the very beginning, of the acculturation and learning that makes healthcare providers into sort of who and how they are seems to me like a very systems-oriented and systematic way of approaching the humanization of healthcare and the sort of harmonization of our healthcare practices with a diverse society. So I'm really attracted to the idea of starting out as we plan to continue. You can't really have healthcare that's focused on patients and their perspectives and their needs and their desires and their autonomy without acculturating the people on the other side of that equation or partnering with them around that care to take that on board at the very beginning. So I think the conference is important for that. I would hope that the next time that this conference occurs, it would be called not where is the patient's voice in health professional education, but where are patients' voices in health professional education. I think that move from the singular to the plural is an evolution that we're talking about here this time, and one that many people are aware of. But it's a hard move to make. We tend to simplify things so we can understand them, and it's easier to think of a patient than of patients, of capturing a voice than of what it really takes to capture multiple voices. So I think it's an understandable evolution, but one I'm impatient for us as a field to get to.
What do you think was involved in that move from conceiving a monolithic patient to conceiving a much more complex view of the singularity of each patient?
I think there's been some wonderful work in many different venues that have led to that. I think there's been activism. I think there's been an articulation of sort of identity politics and what it takes to move beyond identity politics, but also sort of the importance of understanding how what we think of as the standardized patient, which is still a term of art in medical education at least, is not only failing to be inclusive, but can actually be offensive to some people who really don't sort of have the privilege of having some of those standardized experiences that can be assumed. So I think that kind of activism and advocacy and agitation has been a part of it by communities whose voices have been either actively oppressed and silenced or just ignored. I think there's sort of that bottom-up part, and then I think there's a little bit more of a top-down or on the level of professional educators and understanding and a growing literature also that questions of what it means to incorporate lay persons and their experiences into the ongoing development, both of scientific inquiry that leads to tests and treatments in healthcare and also to the education of health professionals, is a tricky business, and that there are some central tenets associated with that. There's a problem, as my colleague, the sociologist Stephen Epstein, has articulated this, I think really, really well. There's always a problem of expertise. What kind of knowledge and capacity do people need to have in order to have input? What do we consider to be legitimate expertise? There's a problem of co-optation. So if you have a patient or a patient's voice, and that patient's voice gets used over and over, and that person spends a lot of time in an organization or in a corporation or in a culture, do they start to become part of that thing and sort of farther from a more distant place where their perspective had more challenge to add into the equation when they come to participate? So the problem of expertise, the problem of co-optation, and then the problem of representation. Are you speaking for yourself and your own story? Are you speaking for a class of people, a group of people, a subgroup of people who you somehow represent? And if you are representing them, how do you know that you're capturing not only your own experience but theirs? And I think that these are tricky questions in the field of advocacy, in the field of engagement, in the field of participatory democracy, really, and that's why they're endlessly interesting, at least to me, and I hope to many of your viewers on this show, and why we need to be sort of pushing on this movement, as you stated it, from the univocal to the polyvocal when we're talking about patient and patients.
So I know you want to have lunch. I just want to ask you, is there anything you want to ask yourself or something that you'd like to talk about? Maybe, I did miss your session, but if you want to talk a bit more about the online curriculum or...
Yeah. So one tool that your viewers might be interested in knowing about is this database of individual patient experience. It's called DIPEX, and if you go to healthtalk.org, you will find the site out of the UK. There's a site out of Canada, and I don't have the URL memorized, but I'm sure you could find it very easily. And the USA is just beginning. I'm starting with a study of young adults with depression with my colleague Nancy Pondy in the United States and a group of other people, and there's other folks gearing up to do other topics. And these are tools where that move from patient voice to patient voices has been made. It's a marriage of a rigorous qualitative research study with a very applied online tool. Patients are not spoken for by the researcher. Those who are interviewed appear on the website in excerpted video clips, so you can hear and see their voices. If they've chosen audio only or text only, you may not see the video, but the majority of them are video clips. And you can get really a good feel for patients' experiences in the plural with a variety of phenomena, I'll just call them, ranging from cancers of all kinds to having a child with ADD or with autism to end-of-life issues. What's it like to be a caregiver for somebody who's sick? What's it like to have heart disease? What's it like to have rare diseases? So it's a wonderful tool. It can be incorporated into curricula of all kinds. It can also be used by people who are having or think they may be having experiences with those same illnesses or caregiver issues. It can be used by caregivers. It can be used by policymakers. So in place of, or in addition to, say, inviting that one patient to come give testimony when policy is being made, to access a resource like this where there's been a methodical and skillfully rendered effort to move to that plurality of voices. The tool lets you do that, and I think is a really good thing for people to be using in an applied sense, and also continuing to think about as we contemplate problems with expertise, co-optation, and representation in the generating and using of patients' voices in the public domain.
I think that's going to be the end of it because we have some competition from there.